So when you see this case is interesting. You see 19-year-old woman came from Thailand, okay? Came in with fatigue, holostolic murmur, fever, negative blood culture, but there is this what give it away. There is subcutaneous nodules and extensor surfaces of both arms, you know. So this kind of and blood culture negative on arms. This they will ask you how to confirm diagnosis or what's the diagnosis here. This one there is a suspicion of acute rheumatic fever most likely. Okay, so what you want to do, you do anti-streptolysin or antibody titer. Okay, so this is what you want to do. There is the peak incidence is age 5 to 15, twice as common in girls. Clinical features, there's major criteria like there's migratory arthritis, carditis, there's nodules, erythema marginatum, Sydenham chorea. This is the major. Minor criteria can cause fever, arthralgia, elevated ESR, CRP, prolonged PR interval, and late sequelae can cause mitral rigor, stenosis. How to prevent that? You've prevented with penicillin for group A streptococci, Streptococcus pyogenes pharyngitis. Okay. So you give penicillin, you check for that, and you treat. So this one diagnosed clinically, but you for confirmation you need the group A strep infection or some kind of test to confirm it. Okay. Now this cases is another interesting case. Okay. So if you see 61-year-old came in with fever, muscle aches, dark urine, you know, myalgia, dark urine, and then hemoglobin is low, like 7.8, and there is urinalysis microscopy positive for urobilinogen. So what is going on? Fever, myalgia, dark urine. There's some sort of hemolysis going on. There's transaminitis as well. Okay, there's some transaminitis, fever, you know. What do you do? Best next step. You suspect some malaria, babesia, all kind of things. So you want to do blood smear, peripheral blood smear. Okay, that can give us an idea. This could be babesia. Babesia, how does it present? Present with fever, myalgia, night sweats, headache, myalgia, arthralgia, anorexia. It's kind of general symptoms. Okay, it can happen with anybody, but what's associated with that as well, hepatosplenomegaly possible, hemolytic anemia, thrombocytopenia, AST, ALT. So when you combine these symptoms with that, this makes increase the likelihood of the babesia. That's all medicine, it's all likelihood. And this is for mild illness. Severe illness usually happens somewhere above 50 years old, acidemia, immunosuppressed, Lyme co-infection. If there is DIC, if there's ARDS, if there's heart or renal failure, if there is splenic infarct or rupture, this could be also an increased risk for babesia. Okay, that's one thing. Okay, now let's go to another case. It's interesting. Okay, if you see 37-year-old came in with abdominal pain, epigastric area with food intake, immigrated recently, like 5 years ago, no HIV or exposure to TB, peripheral eosinophil is like 15%. Okay, so you will see abdominal pain, epigastric food worsen with food, and there is peripheral eosinophilia. Okay, what does that tell you? What could be causing that? What could be causing that is something called strongyloides. Okay, so you want to do serology for parasitic infection. Okay, and this brings us to the discussion of strongyloides. Strongyloides usually southeastern United States. When there's immigration of endemic areas such as Laos, Vietnam, Cambodia, you know, it could be asymptomatic. With peripheral eosinophilia, you can have that, but there's associated with GI symptoms like abdominal pain that mimic duodenal ulcer, but pain worse with eating, chronic enterocolitis, malabsorption with high warm burden. It can migrate to the lung, causes dry cough, dyspnea, wheezing, fever, mild pneumonitis. And the skin can cause serpiginous, raised, erythematous tract, running larva, can cause pruritus as well. There is also can cause hyperinfection syndrome, lead to multi-organ dysfunction, possible septic shock. A stool sample can confirm but are frequently negative. Many patients require serology tests like ELISA, IgG, antibody, endoscopy for duodenal biopsy or aspirate, or string test, entero test as well. Okay. Alright, so we continue with our discussions. There's outbreak of flu, okay? Outbreak of flu in nursing home. So what do you do? Best next step. You do prophylactic antiviral for all residents. Okay, that's what you need to do. And this brings us to do like infection control measure for influenza prevention in healthcare setting. So how to prevent influenza? You want to do immunization for all healthcare workers, standard isolation and precaution like hand hygiene, gloves, hand washing, soap and water, gowns. We want to do droplet isolation and precaution for suspected or confirmed patients 7 days after illness and 24 hours after symptoms resolution. Do private room, face mask. You can do N95 if you do bronchoscopy, intubation, sputum induction, and limit visitor access to people who are infected. Okay, so that you just limit the infection spread. Okay, that's kind of the idea in here. Alright, so someone 30-35 have genital lesion, otherwise in good health. What would you do? You do valcyclovir at the onset of symptoms. Okay, like they usually bring it the way they describe a grouped vesicles, this is HSV1 infection. Okay, somebody who have recurrent herpes, so at the onset of symptoms you just give them that valcyclovir, and then you can do suppressive therapy. If you have more than 4 episodes a year, it's recommended to do so, chronic suppressive therapy. Okay, now another patient, like 33, came from Brazil, had hollow systolic murmur, LV aneurysm, lightheaded, so big heart, so anytime there's only one infection that causes aneurysm in somebody from Brazil, so what's the diagnosis? This is called the trypanosoma cruzi. This is trypanosoma. This is trypanosoma cruzi can cause that infection. It's dilated cardiomyopathy. Okay. Megas cause mega heart, mega colon, mega esophagus. That's the pneumonic part. But usually they're not going to give you all of that. So they just give you dilated cardiomyopathy, left anterior vesicular block as well. Okay. This is how you find that out. Okay. Now another case scenario that's kind of high yield as well. You see 43 came in with like fever, fatigue, anorexia, like poor appetite, and then so you do CT. CT showed lucencies in the skeleton along with bulky mediastinal and abdominal lymphadenopathy. And they ask you what's bone marrow biopsy or what's the diagnosis. This is most likely, it's called non-Hodgkin lymphoma. Okay, so this looks like a non-Hodgkin lymphoma. And how do you diagnose? This is usually associated with AIDS patient, a patient with advanced HIV, CD4 less than 100. This increased risk for non-Hodgkin lymphoma, and usually have B symptoms like these fatigues, night sweats. They can have extranodal disease or Burkitt lymphoma, and large cell non-Hodgkin lymphoma these are the 2 most common lymphoma associated with HIV patient. Okay. Now the question they tell you, okay, patient have sex with HIV patient, want to have sex with HIV with another HIV patient. What do? This patient, you need to have them on two drug therapy, like tenofovir plus imitricitabine. Okay. To qualify, you need to have the negative 4th generation HIV testing, no manifestation of HIV, normal renal function, and documented hepatitis B vaccination status as well. And then you can have that. All right. Now this patient is kind of interesting. You see, 38-year-old came in with just voluntary HIV testing. He has been camping, swimming in the pool, you know. So CD4 right now is 750. So he has HIV. He's been camping, swimming. So what is the risk? They tell you what is the risk of what in this patient. This one, risk of mycobacterium TB, and they bring you a bunch of other things. They bring you pneumocystis, toxoplasma, all these histo. A lot of the other things, they're at risk when the CD4 is lower than 200. This one, because CD4 is fine, and then you just like risk of TB infection at this stage. Okay. Now another case is kind of interesting as well. You see, 23-year-old male, okay, who had hematuria, okay, came from Africa. He drinks beer, and then you do peripheral eosinophilia. Okay, CBC shows eosinophil 9%. Okay, so from Africa, hematuria, eosinophil is high. When you see these things, what is the diagnosis? This is best next step is schistosoma. So you do schistosoma serology. Okay, that's what you need to do. Schistosoma serology. Okay. That brings us to the types of schistosoma. There are 3 different types of schistosoma. There's one in hematopium, which is usually in North Africa, Sub-Saharan, and Middle East. Causes hematuria, dysuria, frequent urination, can cause hydronephrosis, pyelonephritis, squamous cell carcinoma of the bladder. Okay, that's one thing. Another one, Manzoni. Manzoni also in Middle East, South America, Caribbean as well. It causes intestinal symptoms like diarrhea, abdominal pain, intestinal ulceration, can cause iron deficiency anemia as well. And there is the third one is Japonicum, usually in Asia, China, Philippines, Japan, causes hepatic schistosoma, like hepatomegaly, splenomegaly, periportal fibrosis, and subsequent portal hypertension. Okay, so that's kind of about schistosoma management, schistosoma. Okay. So schistosoma, we have different types. So there is a schistosoma hematopium. We said, we talked about let's review. We talked about mitochondrial TB, mycobacterial TB. We talked about tenofovir, imitricitabine, non-Hodgkin lymphoma type with HIV, trypanosoma cruzi as well, dilated aneurysm of the heart, valcyclovir for herpes, prophylactic antiviral or resident. Serology for parasitic infection. Blood smear is helpful, you know, for babesia. Antistreptolysin if there is like rheumatic fever suspected. And that's a discussion summary of the 3rd part of infectious disease.